So today we are going to discuss about the USMLE step 2 CK hematology. That will be our part, and this will be our part 9 of the hematology. And we are going to discuss about the folic acid deficiency, also called the folate deficiency, and hemolytic anemia, which can cause the normocytic anemia. So folic acid deficiency caused by the poor oral intake during pregnancy. If patient have eczema like skin disease, psoriasis, and if a person is chronic alcoholic, can develop folic acid deficiency. Among all of these, chronic alcohol is the most common cause of the folic acid deficiency, and also the poor diet is the cause of the folic acid deficiency. Alcohol causes the inhibition of the folic acid at the GI tract for the absorption, and also can cause the impairment of the enterohepatic cycle. So what is how the alcohol cause the prevention of the absorption of the folic acid? It itself can cause the absorption, problem in the absorption of the folic acid, and also cause the impairment of the enterohepatic cycle. Alcohol can develop the megaloblastic anemia within 10 weeks. We know that an alcohol can develop the myeloblastic anemia. Alcohol can suppress the bone marrow. And what other disease can cause the malabsorption of the folic acid? If patient have tropical sclerosis, giardia, those can create problem in the GI tract, and we will talk about this in GI section. So when GI tract is not in good standard to do his absorption job, it can cause the malabsorption. So folic acid will be one of it. When a person have tropical sclerosis or giardia infection, and he can develop folic acid deficiency. Some people take chemotherapy, for example, with the methotrexate, trimethoprim inhibit dihydrofolate reductase, anti-epileptic medication like phenytoin, primidone, phenobarbital. Those can prevent the absorption of the folic acid in the small intestine. So when someone take the chemotherapy with methotrexate, trimethoprim, phenytoin, primidone, phenobarbital, that can cause the absorption problem. GI tract will not able to absorb the folic acid. And someone has tropical sclerosis, giardia, that can also cause the problem of the absorption of the folic acid in the GI tract, and also the alcohol. So alcohol is the most common cause, and also poor diet, most common cause to have folic acid deficiency. And when person is in pregnancy and the eczema psoriasis, it can increase the demand of the folic acid. So in this case, person can develop folic acid deficiency. So when person has folic acid deficiency, he can have problem in the red blood cell, and it will be the problem in the red blood cell due to deficiency of the folic acid will be like vitamin B12, what we discussed in previous section in USMLE step 2 CK part 8. So vitamin B12, we know that it can cause also neurological problem, but folic acid does not cause neurological problem, but it can cause the glossitis and other GI disturbance. For example, the diarrhea can happen. If the pregnant mother have a deficiency of the folic acid, the fetus can develop the neural tube defect, and by giving the folic acid we can prevent fetus to develop the neural tube defect. And physical exam, we will see like all other anemic disease, skin will be pallor, mucus will be look pallor, and diagnosis will be like all other disease which can cause the anemia. It will be like this, and after you suspect person has anemia, we will do the same thing. Know the hemoglobin hematocrit value first. It is below normal, then we will do the measurement of the mid corpuscular volume and reticulocyte count, and we will found mean corpuscular volume is greater than 100. We will think that he has macrocytic anemia, and he has reticulocyte count is low. Next thing, we will measure the hypersegmented neutrophil, and if we found the hypersegmented neutrophil, we have two choice. One is vitamin B12 deficiency or folic acid deficiency. So we will measure both, and if we found folic acid deficiency, we come to the conclusion he has a folic acid deficiency. But if folic acid is normal, but we are suspecting he has folic acid deficiency, we can measure his the homocysteine level and methylmalonic acid. So in vitamin B12 deficiency, homocysteine and methylmalonic acid will increase, but in folic acid deficiency, homocysteine will increase. And like the vitamin B12 deficiency, red blood cell will be oval macrocyte. So almost red blood cell problem almost same like vitamin B12 in folic acid deficiency. Neutrophil will be hypersegmented, we call it megaloblastic anemia, and decreased band form of neutrophil. So all kind of the neutrophil will be low, the red blood cell will be low, but basophil lymphocyte will be normal. And so CBC will be almost identical to vitamin B12 deficiency. Bone marrow biopsy also will be like vitamin B12 deficiency. Marrow will be hypercellular if we do the bone marrow biopsy, and even red blood cell count will be decrease because this person has producing faulty red blood cell. Most of the case bone marrow will break down the red blood cell. So even the bone marrow is hypercellular. He has low reticulocyte and low count of the red blood cells. His hematocrit value is low. And folic acid, methylmalonic acid is normal. Methylmalonic acid is increased in vitamin B12. Homocysteine increase in both folic acid and vitamin B12 deficiency. And how we'll manage this guy? Give folic acid orally. After replace the vitamin B12 and folic acid, this person has anemia. He will start producing the red blood cell, and he will start using the potassium and iron. So if he doesn't have enough source of iron and potassium in his body, and down the road after some time, it means person can develop hypokalemia and iron deficiency anemia, and this happens due to rapid production of the red blood cell at the bone marrow. And so we have to observe this patient and to know about his potassium level and iron level. If his iron will go down, and he will down the road can develop iron deficiency anemia. So any drugs we mention about which causing the folic acid deficiency due to malabsorption, and we can take this patient off from these drugs, or we can give extra supplement of the folic acid. So folic acid and vitamin B12. Now we're talking about general discussion. Vitamin B12 folic acid deficiency can cause the hypoproliferative macrocytic anemia. Hypoproliferative macrocytic anemia. So what happened? Because we already know chronic alcoholic person can develop folic acid deficiency, and so when a chronic alcoholic person is he has more possible to develop the megaloblastic anemia due to folic acid deficiency. What is megaloblastic anemia? When you see the hypersegmented neutrophil. Alcoholic person also can develop thiamine deficiency. So this person can develop chronic encephalopathy, and you can think that alcoholic person develop folic acid deficiency, his red blood cell is macrocytic, and he developed the hypoproliferative macrocytic anemia, but he's an alcoholic, so he can have thiamine deficiency and he can develop chronic encephalopathy, and this is due to thiamine deficiency. This is not folic acid deficiency. So alcoholic person can have deficiency in folic acid or thiamine deficiency, or can have both. But which one has deficiency, it will show that symptom. So when you see someone has red blood cell problem, same time neurological problem, you cannot say that folic acid is responsible for both. But Because he is a chronic alcoholic, he can have deficiency of both, or he can deficiency one of it or not. So chronic alcoholic can, we know that alcohol can cause myelodysplastic syndrome, and bone marrow will be in a problem, and his microvascular volume will be greater than 100. And alcohol can also cause folic acid deficiency, and he will have segmental neutrophil, and his microvascular volume will be greater than 100. So alcohol also can cause macrocytic anemia by cause the malabsorption of the folic acid, and in this case it will have hypersegmented neutrophil. But myelodysplastic syndrome can also give the macrocytic anemia, but we will not find segmental neutrophil. And so alcohol can cause macrocytic anemia by developing myelodysplastic syndrome, and without having the deficiency of folic acid. In this case, patient would not have hypersegmented neutrophil. So make a note: decreased production of the red blood cell, CBC, decreased production of the red blood cell due to folic acid deficiency. CBC show low reticulocyte. It could happen due to folic acid deficiency, B12 deficiency, iron deficiency, infection, cancer therapy, aplastic anemia. So when we will see that person has a macrocytic or microcytic anemia, most of them in the case we have low count of reticulocyte except thalassemia. And this reticulocyte would stain with the methylene blue. So this is discussion about the folic acid. Now let's talk about the hemolytic anemia. Before we go, we talk a little bit about myelodysplastic syndrome. Myelodysplastic syndrome can produce healthy red blood cell due to bone marrow failure. And old people can also have myelodysplastic syndrome due to bone marrow failure. In this case, we will not find hypersegmented neutrophil, but we will find his microvascular volume is over 100. Hemolytic anemia, normocytic anemia, increased reticulocyte and sudden decrease in hematocrit. So in hemolytic anemia we have normocytic anemia. Mean corpuscular volume will be between 80 to 100. Because his red blood cell is low, his hemoglobin is low, the erythropoietin will increase. That can increase production of the reticulocyte, and if this person breakdown of the red blood cell, it can happen suddenly decrease the hematocrit value, that increase erythropoietin, that increase production of the red blood cell. So his reticulocyte count could be above the normal, and his mean corpus, if it be produced too much red blood reticulocyte, is in corpuscular volume even will be over 100. In hemolytic anemia, most of the case red blood cell have problem we call see caused by the hemolytic anemia caused by intrinsic red blood cell abnormality which cause premature destruction of the red blood cell. We know that lifespan of the red blood cell is 120. In this case, it will be below 120 days, probably 80, for example, 100 days. And it can happen by chronic disease, for example, paroxysmal nocturnal hemoglobinuria, sickle cell disease, hereditary spherocytosis. So these are the chronic disease which can break down the red blood cell and give the hemolytic anemia, and patient could have red blood cell corpuscular volume will be 80 to 100. What is this chronic disease which giving the breakdown of the red blood cell and giving the hemolytic anemia? Paroxysmal nocturnal hemoglobinuria, sickle cell disease, and hereditary spherocytosis. Also, acute disease can cause the breakdown of the red blood cell, which can give the hemolytic anemia, and also called the normocytic anemia. It will be like autoimmune hemolytic anemia, like antibody autoimmune hemolytic anemia, cold agglutinin disease, erythroblastosis fetalis. All is this caused by antibody, and antibody attack the red blood cell and break down the red blood cell. Drug-induced hemolysis, glucose 6-phosphate dehydrogenase deficiency, and this called the acute case of breakdown of the red blood cell. Red blood cell can break down intravascularly, extravascularly. When red blood cell will be break down in the liver or in the spleen, we call the extravascular. When red blood cell break down in the heart, we call the intravascular traumatic hemolysis. We call the mechanical heart valve, calcified aortic heart valve. Other calcified heart valve cause is macrovascular traumatic hemolysis. So we have macrovascular traumatic hemolysis, we have microvascular traumatic hemolysis. When red blood cell break down in the heart, we call the macrovascular traumatic hemolysis. What is this? Like mechanical heart valve, calcified heart valve. This thing can give macrovascular traumatic hemolysis. If person develop thrombocytic panic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, patient can have a breakdown of the red blood cell. We call it microangiopathic hemolytic anemia. And we have to know that what intravascular destruction of the red blood cell could do, So when red blood cell will be break down before 128 days, all of this will cause the red blood cell to break down before 128 days. So red blood cell lifespan will be shorter. And when a person has red blood cell breakdown intravascularly, it can lose iron through the urine, and person can develop iron deficiency, anemia, and his mean corpuscular volume can go down 80. So it will be not happen very quickly, but it can happen. This person initially has mean corpuscular volume in normal range, up after loss by trauma or lose iron through the urine, patient could develop microcytic anemia due to iron deficiency. And this person also can develop folic acid deficiency, because we know that our body does not store a lot of folic acid in one time. When person is starting producing a lot of red blood cell, and folic acid need to produce red blood cell, when demand of the folic acid go very high, and if we cannot meet the demand of the folic acid, and person can develop folic acid deficiency, and he can also develop macrocytic anemia. So clinical presentation of the hemolytic anemia, how it will be sudden, it will be chronic, it will be macrocytic. Patient can have hemolytic anemia, patient can develop macrocytic anemia, microcytic anemia. And when anytime we break down the red blood cell, it can give us bilirubin will start producing, and hemoglobin will be in the urine. It can give the dark urine, and hemosiderin will be stored in the skin, in the eye. It can give the pigmentation, so patient can develop the jaundice due to red blood cell breakdown, increase the hemoglobin. And when red blood cell will be breakdown and bile will be start producing, it will go to the gallbladder, and it can cause the gallstone. And very rapid, like say glucose 6-phosphate deficiency, can cause the very rapid breakdown of the red blood cell, and it can cause the hemolytic anemia. If a person break down the red blood cell very rapidly, like the case in glucose 6-phosphate dehydrogenase deficiency, and patient can develop fever, chill, chest pain, back pain, and he can develop tachycardia because due to flow murmur. And physical exam, you will see the carotid pulse, you can feel. And all kind of anemia is depend how bad it is moderate to severe, moderate, mild to moderate, moderate to severe, or very severe. And symptom will be show based on it. Also history, young person, old person also have a different response in different hematocrit value. Also same time, if person has arteriosclerotic disease, he can even have normal hematocrit value, still he can show the symptom, for example like chest pain. So if we do the physical exam, we will see the jaundice. What is the jaundice actually mean? When hemosiderin, what is hemosiderin? Is the iron. Iron will be stored in the body without harming it. We call it hemosiderosis. It can give the pigmentation of the skin, and patient could have jaundice. So this person, if this person is old man, and we know he's having anemia, and his reticulocyte is high, red blood cell count is low, and we are thinking person could have hemolytic anemia, and we will look for any it can cause by like calcified aortic heart valve or mechanical aortic heart valve. And if person has this thing on there, and which may cause the breakdown of the red blood cell, in physical exam we can find he could have systolic ejection murmur. When blood will go through this abnormal valve like calcified aortic valve, or person is in mechanical head valve, the heart valve, mechanical aortic heart, his ejection systole, we will, when we do the physical exam, we will find ejection systolic murmur in the aortic area. And he is developing hemolytic anemia. His mean corpusculum volume usually will be normal range, but after some time he may lose iron and he can have iron deficiency anemia. In this case he can have microcytic anemia. If he has folic acid deficiency, he can even have macrocytic anemia. And if we look at his urine, we may find iron in the urine. So his hemoglobin, we are thinking he has anemia. First we will do the hemoglobin hematocrit, then mean corpuscular volume, and the reticulocyte. We will find mean corpuscular volume is a normal, reticulocyte count is high. This is give us hints he has a hemolytic anemia. So why his reticulocyte number is high? Because he has anemia. He is developing increased erythropoietin that can cause increased production of the red blood cell, and he have too many reticulocyte in the system. His main corpuscular volume will be may increase slightly. We call it polychromatophilia. So what we know, we found his reticulocyte is high due to breakdown of the red blood cell, and if his mean corpuscular volume slightly increase, and we call it polychromatophilia. And this person can develop, we already talked about folic acid deficiency, because our body cannot store lot of folic acid. When there is a rapid increased production of the red blood cell, we may develop folic acid deficiency, and patient could develop macrocytic anemia. And when there are a lot of red blood cell will be breakdown in the macrovascular system or microvascular system, like say in the heart, or patient develop thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation. It causes the breakdown of the red blood cell, and cell inside of the cell has a lot of potassium, and it will be in the system, and person can develop hyperkalemia. Anytime a person break down the red blood cell, and he can develop unconjugated bilirubin. So his bilirubin, unconjugated bilirubin, will increase. I will talk about what is the fate of the breakdown of the red blood cell, what happened. So in a normal person, we know the bilirubin is 0.2 to 1 milligram deciliter, and person is breaking down the red blood cell. Usually our bilirubin will not go above 4. But if the same person is break down the red blood cell, same time he has a problem in his liver, and he have a liver disease, or he has a bile obstruction, and this person his bilirubin could go high if above 4. Other case, if he has a normal liver, no bile obstruction, his bilirubin will be stay below 4. Normal person has bilirubin 0.2 to 1 milligram deciliter. So when there are a lot of red blood cells will be start breaking down, we will produce bile, and that will go to the gallbladder, and it can cause the cholelithiasis, cholecystitis. Chest pain, cholecystitis is the infection in the gallbladder, and patient will show right upper quadrant abdominal pain due to development of the bilirubin gallstone. So anytime a person is hemolytic anemia, his possibility to develop bilirubin gallstone is high. That can be cause to give him the right upper quadrant abdominal pain due to the cholelithiasis, cholecystitis. Anytime red blood cell will be break down, his lactate dehydrogenase will be increase. So a person has the hemolytic anemia, we draw the blood, we put in a slide, and we put this under the microscope. What we will see in peripheral smear, we can see the pigmented red blood cell, cystocyte helmet cell caused by artificial heart valve, DIC, distinct vascular coagulation, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. When red blood cell will be break down, and we will see the cystocyte helmet cell. We know that red blood cell will be break down in the spleen and liver. When it break down in the spleen or liver, we don't call it peripheral breakdown of the red blood cell. When red blood cell will be break down in the heart or in the blood vessel, we call it peripheral breakdown of the red blood cell. When red blood cell would be breakdown in the peripheral system, like in the heart or in the blood vessel, due to thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation. In this case, we will see cystocyte helmet cell. And if this person breakdown in peripheral breakdown of the red blood cell, if we do the urine analysis, we will find the presence of the hemoglobin and hemosiderin, and this happen when person has intravascular hemolysis. When person has breakdown of the red blood cell in the liver or spleen, we will not see hemoglobin, hemosiderin. And when breakdown in peripheral breakdown of the red blood cell, like intravascular and breakdown of the red blood cell, we will find this person can develop microcytic anemia. due to loss of the iron through the urine. And when red blood cell breakdown in the spleen or the liver will not give hemoglobin, we will not lose the hemoglobin through the urine, so he is not losing iron through the urine, and this person will not develop iron deficiency, and he will not have iron deficiency anemia. So red blood cell breakdown in the spleen and liver will not give iron deficiency anemia. When red blood cell breakdown in the peripheral vascular system, we also call the intravascular hemolysis, and this person can have hemoglobinuria. Hemoglobin come to the urine when have haptoglobin is low, and when has hemoglobinuria, and he can develop he can lose iron through the urine, and he can develop iron deficiency anemia. So chronic hemolysis, like in case of the calcified heart valve, also can macrocytic anemia due to loss of the iron through the urine. In this case, urobilinogen will increase. I will talk all of this in later, how urobilinogen, all this will be formed. And severe hemolytic anemia, in severe hemolysis, and when person has severe hemolysis, suddenly he is breaking down lot of red blood cell. We know that when red blood cell break down in a normal person, there is a haptoglobin in our serum, and it will bind down with the hemoglobin and not let it lose through the urine. And when there are a lot of breakdown of the hemoglobin, haptoglobin will be not enough in the system, so we will have pre-hemoglobin. This pre-hemoglobin will go to the urine, and that will be lost through the urine, and patient can develop iron deficiency anemia. And when have too much iron in the urine, our kidney tubule try to absorb it. When it will absorb too much iron, and it become the hemosiderin, and this hemosiderin will be sloughed up, and that will be lost through the urine. I will talk about also in later little bit of it. So if we do the bone marrow biopsy, we usually find normoblastic erythroid hyperplasia. So his bone marrow is producing blood more than normal amount, more than like a compared to the normal person, so he can have normoblastic erythroid hyperplasia. So what we will do to this patient, like we talked before, if this person is young and his hematocrit value below 20, and but no symptom, probably we will not do anything. But is he have a symptom, his hematocrit value is below 20, anytime have symptom, we will give him blood. We transfuse him packed red blood cell, and when it will be below 20, we may think he may going to develop anemia symptom. In this case, we may think to give him blood. And the old person, if he has a coronary artery disease, his hematocrit value is below 30, we will give him blood. So if a person is suddenly breaking down a lot of red blood cell, what could happen to his kidney? This hemoglobin will go to his kidney, and hemoglobin is a cause the toxicity to the kidney. So how we can prevent him? Give him a lot of fluid, and also diuretic like mannitol. Mannitol is not absorbed through the mouth, so we give him the intravenous mannitol and also intravenous IV fluid. So when IV fluid and mannitol will be increased, and it can prevent the toxicity of the hemoglobin by producing a lot of urine. And we have to know which disease is causing the hemolytic anemia, and we have to treat it to prevent the hemolytic anemia. Anytime any patient has hemolytic anemia and his reticulocyte is high, his erythropoietin is high, he is producing a lot of red blood cell, he can be run out of folic acid. So we must have to keep up with folic acid by giving him extra folic acid supplement. So let's talk about little bit a little note about breakdown of the red blood cell. Red blood cell breakdown in the circulation. So now we are talking about peripheral breakdown of the red blood cell, extravascular breakdown, the intravascular breakdown of the red blood cell. Intravascular breakdown is macrovascular and microvascular. When red blood cell breakdown at the heart, we call it macrovascular. When red blood cell breakdown in the artery, we call it microvascular. Microvascular breakdown of the red blood cell usually happen when patient has thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, or narrow down of the red blood cell by other reason. So when red blood cell will be break down, hemoglobin will be bind with haptoglobin. When red blood cell will be break down in the vascular system, red blood cell will be release the hemoglobin, it will be bind with haptoglobin. When too much red blood cell will be break down, no haptoglobin will be left to bind hemoglobin. So hemoglobin will be at the urine. When red blood cell break down at the spleen, and hemoglobin bind will be albumin. I'm talking about the spleen and the liver, which will become the bilirubin. So in the liver and spleen, when hemoglobin will be bind with albumin, and we call it bilirubin. When too much red blood cell will break down at the spleen, we are talking about too much, and hemoglobin will expel in the circulation without able to bind with the albumin. So hemoglobin will be found in the urine. Usually this not happen because we have lot of amount of albumin storage compared to the haptoglobin. So albumin will not be depleted easily like haptoglobin. So extravascular hemolysis would not easily lose iron through the urine. So usually when red blood cell breakdown in the spleen or in the liver, usually we don't develop the iron deficiency anemia. When we break down the red blood cell peripherally, like microvascular in the heart or in the macrovascular in the artery, we have more possibility to develop iron deficiency anemia. So in this case, hemoglobin, we have heme and globin part. So which part we are dealing with on here? Heme part from the hemosiderin. So in the hemolytic anemia, we usually deal with the heme part. We not deal with the globin part. This heme part, if the bilirubin, it can store the hemosiderin in our skin, and it can give the pigmentation that can cause the jaundice. So let's talk about general thing, you know, and so before we go talk about general thing, we have to make sure that person has enough folic acid, person is not developing iron deficiency, anemia. So we have to follow this patient for this, and we have to know what is exactly causing this person to have hemolytic anemia, and we have to take care of it. So general discussion about after breakdown of the red blood cell. So blood cell, again just repeating it, so you can, if you don't understand before, so you can understand now probably. So blood cell could destroy in the heart or inside the blood vessel. When patient has a mechanical heart valve called the intravascular destruction of the red blood cell. When red blood cell destroy in the spleen or in the liver, we call the extravascular destruction of the red blood cell. Destruction of the red blood cell is variable. Right, same disease could have a small number to big number of red blood cell destruction. Clinical presentation of the severity of the anemia depend on how much of the red blood cell was destroyed and how fast rather than what disease is causing the destruction of the red blood cell. So if any disease can cause the destruction of the small amount of red blood cell or big amount of red blood cell. So anemic symptom depend on how quickly and which disease, how much red blood cell was breaking down. Example like sickle cell disease destroyed very few cell, patient could not have any anemic symptom. If sickle cell disease destroy a lot of red blood cell, patient could show the severe anemic symptom. Clinical presentation of hemolytic anemia is sudden or patient probably will not show any symptom. Patient could have macrocytic anemia if have folic acid deficiency, microcytic anemia it have folic acid deficiency. And before we talk about the macrocytic and microcytic anemia, those anemia usually develop gradually, but hemolytic anemia patient could have suddenly he can develop anemia. So hemolytic anemia patient could suddenly develop mild anemic disease or suddenly severe anemic disease, and red blood cell is normocytic, and so hemolytic anemia can have develop anemia suddenly, and it would be severe, or he can have mild anemic disease. And blood loss, someone has a trauma, he losing blood, he can also have normocytic anemia, and his reticulocyte also will increase and his mean corpuscular volume will be normal, but after certain time if he has iron deficiency anemia, and he can develop a microcytic anemia, and he is producing red blood cell, he can develop hypokalemia, and but when red blood cell breakdown he can has hyperkalemia. So hyperkalemia can develop earlier than the hypokalemia. Hypokalemia happen due to increased production of the red blood cell. Hyperkalemia happen due to breakdown of the red blood cell. Hemolytic anemia patient has all the symptom of macrocytic microcytic anemia patient has. In addition to that, hemolytic anemia patient has jaundice and dark urine. Why? Because of the bilirubin, because of the hemocyanin. Red blood cell breakdown release the iron store in the skin, it give the pigmentation of the skin, and it give the jaundice. Red blood cell breakdown, hemoglobin go to the urine, and iron will be try to absorb in the renal tubule, and when too much red blood and iron will be stored, slough of the the renal part of the renal tubule, and we will see the iron in the urine, and it give the dark color of the urine. So reticulocyte will be, we already know that person has hemolytic anemia, he is producing a lot of reticulocyte. When this is the case, his mean corpuscular volume will be increased. We call it polychromatophilia. When patient has sudden or severe hemolysis into the circulation, intravascular hemolysis, patient could spill hemoglobin into the urine, and patient could has hemoglobinemia, hemoglobinuria. So patient is breaking down red blood cell in the artery. He could have hemoglobinemia, and this hemoglobin go to the urine and through the kidney, and he could have hemoglobinuria. But when hemoglobin bind with the albumin, like say person break down red blood cell in the spleen, and hemoglobin will be break down with the albumin, we call it indirect bilirubin or unconjugated bilirubin. When this indirect bilirubin will go to the liver, and this bilirubin will be bind down with glucuronic acid, we call it direct bilirubin or conjugated bilirubin. This bilirubin will not spill into the urine. In severe hemolytic anemia, a lot of hemoglobin, and there are a stable amount of the albumin in the serum. So there is a if really very big amount of hemoglobin will be, red blood cell will be break down, and albumin will be low, then he can have free hemoglobin. And this is the case of the red blood cell breakdown in the spleen. But when breakdown in the artery, his haptoglobin will be low, and he will have, person has a free hemoglobin that can come to the urine, and person can have hemoglobinuria, and he could have iron can give the urine in dark in color. If a person has less severe hemolysis, urine analysis would not see the hemoglobin, because hemoglobin will be bind with the haptoglobin, and hemoglobin will be not free, so it will be not come to the urine, and it bind with the haptoglobin. So when person has breakdown of the when person has a breakdown of the red blood cell in the, like say person has a intravascular hemolysis, and his haptoglobin will be low, and it could cause the iron to hemoglobin to come to the urine, and the hemoglobin carrying the iron, and it will be metabolized, and iron will be absorbed by the tubule. Then it will be develop hemosiderin, and hemosiderin will be sloughed off. That can give the dark color urine. So hemosiderin is detected in iron stained urinary sediment in sloughed renal epithelial cell. Again, hemosiderin is detected in iron stained urinary sediment in sloughed renal epithelial cell, because we already talked about that when hemoglobin increase in the system, it go to the urine and it will be metabolized, iron will be absorbed, then when iron will be absorbed, iron will make the hemosiderin. When hemosiderin will go high, it will be sloughed off, and then urine will lose the iron, and person can develop iron deficiency, anemia, and also urine color will be dark in color. When urinary hemoglobin is reabsorbed by renal tubule, it is processed to hemosiderin. I already talked, I'm just repeating again. So urinary hemosiderin reflect hemoglobinuria. So, and suggest severe or intravascular hemolysis. So when we will see the iron in the urine, what it gives us, it predicts us person is developing severe hemolytic intravascular severe or intravascular hemolysis. If person has severe hemolysis happen going on in the spleen, his hemoglobin will come to the urine, and it can cause the hemosiderin, and the color of the urine will be dark and give us hint that he has a severe hemolysis. Or if he has iron in the urine, it can give us the hint that person has intravascular hemolysis that can cause the iron to come to the urine. You have to think very deeply on two things going on in here: spleen or in the peripheral system, like in the macrovascular hemolysis or microvascular hemolysis. Both can give iron to come in the urine, and it can give the urine in dark in color. So what is hemosiderin? Hemosiderin is insoluble form of tissue storage iron, which is visible microscopically both with or without use of special stain. When we metabolize hemoglobin, go to the urine, the urinary tract, in the tubule, metabolize, iron will be absorbed. Then this iron will be stored in hemosiderin form, and in the tubule, when it will have a lot of hemosiderin, it will be sloughed off, and we will lose iron through the urine. So again, hemoglobin breakdown from hemosiderin, and hemosiderin could spill into the urine, and we could lose the urine, and we can develop iron deficiency, anemia. And we know that hemoglobin bind with the haptoglobin and form bilirubin, and they bind with the albumin. So hemoglobin bind with haptoglobin, form hemosiderin, that will form the bilirubin, and bilirubin will bind with the albumin. So hemoglobin go through some stage before it will form the bilirubin. When patient has massive hemolysis, hemoglobin and hemosiderin spleen in the urine, expel in the urine. When hemoglobin forms into the bilirubin, it will bind with the albumin. Before form the bilirubin, hemoglobin, hemosiderin will expel into the urine. So it can give the yellow color of the skin or dark color of the urine is due to presence of the iron. So what is the fate of the hemoglobin? It will go through different stages and it will form the bilirubin. It will form the hemosiderin, and hemosiderin could expel in the urine. Hemoglobin bind with haptoglobin, form hemosiderin, and after some process it can form the bilirubin, and this bilirubin will bind to the albumin, and this bilirubin albumin will go to the liver, and it will from when it bind with the glucuronic acid, then it will form the direct bilirubin. Before it will be when bilirubin bind with albumin, we call it indirect bilirubin. So hemolytic anemia can increase the unconjugated, we also call indirect bilirubin, but it will not go greater than 4. When person has bilirubin greater than 4, we have to think that person could have problem in the liver, or his the biliary tract has in trouble. So hemoglobin is like toxic, like a myoglobin. We know that to the kidney. So when person is breaking down a lot of red blood cell, we have to give him plenty of fluid and also diuretic like mannitol intravenously to produce a lot of urine to prevent the toxicity of the hemoglobin. Myoglobin also, when someone has a smash of the muscle, he will release the myoglobin, and myoglobin also toxic to the kidney, and in this case we also give him IV fluid and IV mannitol to produce a lot of urine. In macrocytic and microcytic anemia, patient has a low count of reticulocyte, or it could be normal. We talked about before, and it could happen slowly, but in hemolytic anemia, patient reticulocyte will be higher or normal. Only in microcytic anemia, reticulocyte could be normal only in thalassemia. Hemolysis of the red blood cell release. Now we have to look at what is the fate of the hemoglobin after the breakdown of the red blood cell. So breakdown of the red blood cell release free hemoglobin, which will bind with the haptoglobin. So haptoglobin will not be loosed through the urine, and when patient has severe hemolysis, haptoglobin is bind with the hemoglobin. So there is no free haptoglobin left, and serum haptoglobin will be low, or serum or no haptoglobin. As long as haptoglobin is available, serum haptoglobin will not increase. Haptoglobin is available, hemoglobin will not increase. So when no haptoglobin is available, serum hemoglobin will increase. When have free hemoglobin in the serum due to lack of haptoglobin, free hemoglobin will come to the urine, and remember that hemoglobin is toxic to the kidney. It can damage the kidney. In this case, we have to give him IV fluid and also IV mannitol to increase production of the urine. So what is hemosiderin? Siderosis, it is a collection of the iron, like focal or general increase in tissue iron storage without associated damage to the tissue, we call it hemosiderosis. When too much iron will be stored in an organ, it can also damage the organ. For example, iron storage in the heart, iron storage in pancreas, iron storage in the liver, iron increasing the pituitary gland, iron increasing in the skin can happen, and it can damage those organs. Hemolytic, remember that hemolytic anemia does not cause the increase in the serum iron. Only serum iron will increase when patient has hemochromatosis. So even we are dealing with the iron here, hemolytic anemia does not increase serum iron unless the person has genetic disease like hemochromatosis that can increase the serum iron, and it can increase the iron storage in the different organ. For example, pituitary gland, skin, heart, liver, and pancreas, and it can cause the disease of it. Red blood cells have collected body of iron, which is hemosiderin. Anything cause the hemolytic, like say mechanical heart valve and microangiopathic hemolytic anemia, spherocyte red blood cell, enzyme deficiency like glucose 6-phosphate dehydrogenase deficiency, whatever caused the destruction of the red blood cell, peripheral blood smear will show the cystocyte and helmet cell. Patient haptoglobin will be low, cystocyte only see when red blood cell breakdown occur in the intravascularly, peripheral breakdown of the red blood cell in the heart or in the artery, due to problem happen, for example, thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation, and mechanical heart valve can cause the red blood cell destruction. We will find the cystocyte and helmet cell due to intravascular hemolysis. And when red blood cell breakdown in the spleen or in the liver, we call it extravascular hemolysis, and we will not see a cystocyte and helmet cell. Microangiopathic hemolytic anemia is a traumatic intravascular hemolysis, and thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation causes the microangiopathic hemolytic anemia, and that we call is intravascular hemolysis, and it can increase cystocyte helmet cell. Red blood cell will be fragmented, and in peripheral blood smear we will see again cystocyte. So mechanical heart valve can cause macrocytic traumatic hemolysis. So let's just read one time from my note what is the fate of the heme in normal person. As a red blood cell go to the spleen or in the liver, default a red blood cell in the bone marrow, destruction of the premature red blood cell in the bone marrow, destruction of the red blood cell by phagocyte cell in those organs, it will release the heme, and it will form the biliverdin. Biliverdin react with the enzyme biliverdin reductase, it will form the bilirubin. and bilirubin is insoluble in aqueous solution, and bilirubin from outside the liver bind with albumin in the serum. So bilirubin and albumin from the indirect bilirubin. Bilirubin, albumin will be bind and it will go to the liver. And in the liver cell, bilirubin bind with the glucuronic acid by the uridine diphosphate glucuronosyl transferase, and it will form the bilirubin glucuronidase. It will be water soluble. So bilirubin when bind with albumin, it is not water soluble. When bilirubin will be bind with glucuronic acid, it will be water soluble. We call it conjugated bilirubin, which is non-toxic, and this happen in the liver, and it will be secreted into the bile, and it will go to the bile duct. From the bile duct, it will go to the duodenum in the GI tract, and in the GI tract, bilirubin glucuronidase will be separated by the bacteria beta glucuronidase and form colorless urobilinogen. 80% of the urobilinogen will be excreted to the feces, and it will give the stool in yellow color. If patient has obstruction of the bile, and the urobilinogen will not come to the stool, and it will give the white pale looking stool. In normal person, 20% of the urobilinogen will be absorbed in the ileum and colon. This 20%, from this 20%, most of it will go to back to the liver and secrete through the feces, and a small portion of it will go to the blood, and there it will go to the kidney, and it will excrete through the kidney, and it will give the urine color yellow. We are talking about the fate of the urobilinogen. Most of it will excrete to the feces, some of them will be absorbed and it will go to the liver, and some from it will go back again to the GI tract, and it will be excreted through the GI tract, and a small part will go to the blood, and it will come to the urine, and it will give the yellow color urine. When massive hemolysis occurs, some of the bilirubin will not be bound with the albumin, so it will be free bilirubin. Unbound bilirubin increase cause jaundice, because our body system will store the hemocysteine. Some drug even can displace bilirubin from the albumin, and unbound bilirubin will increase. It can also cause jaundice. When bilirubin glucuronidase does not form, like any disruption of the any disruption of the formation of the bilirubin glucuronidase, and bilirubin glucuronidase is water soluble called bile formation, which excrete through the body through the feces and urine, and result in increased free bilirubin. So what we are talking about is here, in normal person, bilirubin plus albumin will come to the liver, and it will form the bilirubin glucuronidase. This is water soluble, and it will be excreted to the feces. But if person has a liver problem, he will not form the bilirubin glucuronidase, and he will have free bilirubin, and bilirubin is a pigmented substance, and it will give the yellow discoloration of the skin, and the also escalator and cause the jaundice. This, if this person have liver disease, for example, he has liver disease due to hepatitis B or hepatitis C, and his hepatitis cell is not working properly, he is not able to produce bilirubin glucuronidase, and so his bilirubin will be high, and that can cause, and his bilirubin will be expelled in the system, and it will go to the blood vessel, it will be stored in different organ, in the eye, in the skin, and he will have his skin color will be changed, and he will have the sclera of the eye color will be changed, and we will call it jaundice. So when bilirubin does not bind with the glucuronic acid in liver, we call it unconjugated bilirubin. Unconjugated bilirubin is bound to the albumin, and when bilirubin is bound with the albumin, we call it unconjugated bilirubin. When bilirubin bind with the glucuronic acid, we call it conjugated bilirubin, and this will be excreted through the feces. Unconjugated bilirubin is the pigmented substance and which cause the jaundice. So unconjugated bilirubin is the responsible to cause the jaundice, and because it is not water soluble and it can go to the system, and unconjugated bilirubin cannot secrete through the urine due to it binding with the albumin, and unconjugated bilirubin is not water soluble. So this one I just discuss about, so you can understand about the what's going on about the fate of the hemoglobin. So this will be our USMLE step 2 CK part 9, USMLE step 2 CK hematology part 9, and I was talking about the folic acid deficiency and hemolytic, general discussion about the hemolytic anemia, and I will go each individual disease is responsible to cause the hemolytic anemia and cause the increased production of the reticulocyte.